you. Sorry about that. So I have the pleasure today about talking about recurrence, which I personally think is one of the most important post-TB lung diseases, because approximately 700 to 850,000 people previously treated for TB each year are diagnosed again with TB. This is approximately 80% of all TB globally, and people with previous TB have a TB incidence rate of 2.26, which means for every 100 people with previous TB that you follow up for a year, you will get approximately 2.26 new cases. And in the South African TB prevalence survey that was recently completed, only 8% of the random sample of people had a history of TB, but these individuals contributed 27% to the total amount of TB detected within that prevalence survey. And importantly, it appears that TB cases who have a history of TB have higher transmission potential. For example, in the prevalence survey, when you look at TB cases who had symptoms, 38% of them had a history of previous TB, compared to only 18% of cases who were detected without symptoms. We know that targeted active case finding in people with previous TB is cost effective, and this is partly reflected in the TOUCH strategy in South Africa, where people with a history of TB should receive a TB test regardless of their symptomology. And we know that targeting people with a history of TB is also further enhanced by by the provision of targeted preventative therapy, given the high future risk of TB. And in Cape Town, where we are obviously close to now, you can see that approximately 30% of people who are tested for TB have a prior history of TB. So this is really an area of the world where previous TB is a massive problem in terms of these people requiring future testing. And I think it's also important to think about the diagnosis of recurrence as not just being about the diagnosis of recurrence itself, but also being essential to open doors for the investigation of other post-TB sequelae. So my slides are mostly going to focus on two areas: the assessment of risk factors and if they have any diagnostic utility, as well as potential approaches for the diagnostic confirmation of recurrent TB. I'm not going to distinguish between reinfection and relapse, because I think clinically, although there may be some differences, they should be treated in a very similar way. So in terms of risk factors, many of the things that we know are risk factors for TB are themselves risk factors for recurrence. I think what's important is that the recency of the previous TB episode is one of the strongest predictors of recurrent TB. A general rule of thumb that is often used, although it's largely based on expert opinion, is within the last 2 years. Importantly, the number of previous TB episodes is an extremely strong predictor of recurrent TB. The more prior TB you've had, the more future TB you will get. There's an exponential increase in your future risk of TB. There's also information, and this is a very active area of research, from the previous episode of TB, and whether at the end of treatment that is potentially useful for the prediction of recurrence. But unfortunately, that information in resource-limited high-burden settings is currently seldom available. So risk factors overall have suboptimal sensitivity and specificity for current TB. They're partly confounded by the different biological mechanisms that underpin relapse versus infection. I think one area for research and where there are opportunities are for personalized risk prediction scores for risk of recurrence. And it's unfortunately, the honest truth is that we don't really know which tests perform well in different types of people with different risk factors. The same is largely true for biomarkers. Generally, in TB, we have a dearth of good biomarkers for active disease. We know even less about them in the context of the diagnosis of recurrent TB. The biomarker with the most evidence to support its use, which is WHO endorsed for the diagnosis of TB, is C-reactive protein, where it outperforms symptoms in the context of HIV. The largest study on C-reactive protein found no difference in diagnostic accuracy based on the previous TB status. And it's possible that some markers that are related to mechanisms of recurrence, such as iron homeostasis markers and anemia, have low sensitivity but very high specificity for recurrent TB. And simply put, we need more data here. However, people with so-called normal levels of some biomarkers may not need further investigation. So in terms of moving on to the microbiology, the test we all rely on a lot are TB-DNA tests, and this is DNA can persist in the body for years after treatment cure. And this is a graph showing that at the end of the treatment with GeneXpert, approximately 30% of people are expert positive. And this is a real problem, right? So in Cape Town, because we have such high rates of previous TB, about 1 in 3 expert ultra positive results in people with symptoms in the last 2 years are culture negative. And that's really a poor positive predictive value. I think TB PCR testing cannot totally be thrown out the window, right? I think if you test negative, your odds of recurrence are relatively low. If positive, you can check if the drug susceptibility result has changed. An open research question is whether the bacterial load readout has increased since the previous episode, and you can have more confidence in a TB PCR result as time passes. I wanted to very briefly, talk about PCR positive, culture negative TB. We are only beginning to understand the nature of these patients and how to treat them. But importantly, in people who are GeneXpert ultra trace positive, culture negative, if you do not treat them, they have a very high risk of future incident TB, right? So they have a hazard ratio of approximately 34. So this might be a form of incipient or culture negative TB. How do we treat them? We are not sure yet. And unfortunately, for most of the microbiology, it seems close follow-up is presently most prudent, and imaging can be used where possible. And we are shortly entering uncharted territory because we have a wave of successor technologies to GeneXpert Ultra, and we have no clue how they are affected by the presence or absence of old TB-DNA. Culture, this is an old workhorse, but it is still one of the best tests available for recurrent TB, but be aware of its limited sensitivity. A single culture has approximately 84% sensitivity in someone with symptoms, probably far less in people with asymptomatic TB. In special patient groups like ART initiators who often have very paucibacillary disease, you need 2 cultures to confidently be able to say whether or not TB can diagnose. Obviously, culture is slow, and there are challenges in sputum-scarce people. But it's presently the only routine method that's available to confirm MTB viability and consider 2 cultures in people with suspected recurrence. One of the most promising molecular assays on the horizon is the TB mycobacterial load assay developed by Wilbur Sabiti from St. Andrews University. This is close to commercialization, and it detects ribosomal RNA in hours directly from sputum. And importantly, in this graph showing the readout of different tests from people on treatment, GeneXpert Ultra remained positive at the end of treatment in 33% of people, but this RNA-based assay practically was negative in everybody. And this is one of the few tests where they've specifically evaluated it for its ability to distinguish recurrence from post-TB lung disease. And in this Tanzanian study, the TB mycobacterial load assay was highly concordant with culture in people who were expert positive, and was able to prevent unnecessary TB treatment in many of them. It's currently a lab assay, its user-friendliness is increasing, and it's the only molecular test evaluated thus far for recurrence in people with post-TB lung disease. I'm going to move very quickly because I'm running out of time. There are a bevy of new pathogen tests here, such as new generation LAM assays, free DNA in the blood, as well as tongue swab testing for TB. But we don't really know how well enough they perform yet for TB itself, especially by previous TB status. In terms of imaging, computer-aided detection performs better than human readers, but has diminished specificity in people with previous TB. And I could find one study on computed chest tomography that thought that necrotic mediastinal lymph nodes were the diagnostic feature most discriminatory for recurrent TB. And we need more data to train these algorithms. So in conclusion, and I apologize for going over time, ruling out recurrence, especially in people with symptoms, should be viewed as a gateway to post-TB care. There's nothing yet to suggest that biomarker performance by previous TB status is affected, and standard microbiological tools, despite their limitations, for now remain the best. Context, pretest probability, and population are all critical. We need dedicated diagnostic studies to longitudinally assess people at risk of recurrence. And while putting together this presentation, it really struck me that people with previous TB are not currently designated as a special population group in TB diagnostic development guidance, and they should be. If you have a post-TB lung disease cohort and you would like to explore new technologies in it, please come speak to me. Thank you.